Okay, 7:35. Good evening all to the Weekly Huddle. My name is Anup Agrawal. I'm an interventional cardiologist at Care Hospital. I'm joined in the session by my co-host and colleague, Dr. Praneeth Palamari. The Weekly Huddle is an unscripted audience-level interaction where we discuss common clinical scenarios. Sometimes they are directly patient-related, and sometimes they are not directly related to a particular pathology aspect, but mostly about patient care, which is particularly what today's topic is. We aim to keep the discussion patient practice oriented, so we typically pick up a case or a topic and we restrict our discussion around that. The basic premise of the huddle is to bring our casual hallway discussion to a more organized platform like this to share our ideas. Today's topic is less science-based and more practical oriented. That is why we're not going to talk about what the guidelines suggest, rather what we as a general do in our daily practice. We host our session every Wednesday at 7:30 p.m. This is our third session, and we are discussing about how and what we advise to our patients who plan to go abroad, particularly in the States, where many of our patients intend to stay for longer duration, and how we typically manage our patients. We will talk about cardiovascular aspect, and then we will expand the discussion on non-cardiovascular aspect as well, because sometimes we do end up discussing that as well because of their long-term stay. So having said that, I will start today's clinical discussion. I have posted the clinical case on the chat box as well for people who would join later on. This is a routine clinical case that we see it on our daily practice, and I just would like to invite the attendees' opinion about how they would handle it. So, Praneeth, you get the first shot at it. Let us know what your thoughts are, and then we'll open it for discussion to others. So, this is a 60-year-old female. She has got diabetes for about 20 years now, hypertensive, which she was diagnosed around 5 years ago. At that time, she had some chest discomfort, which was classified as unstable angina. An angiogram showed mid-LAD lesion, for which she underwent percutaneous angioplasty. This information I got from her previous doctor's note. I don't have the actual detail of the angioplasty. She comes to me for a routine follow-up. This is her second visit to me. She is otherwise feeling fine. She does not have any symptoms to report. She came to me primarily to get my so-called clearance because she intends to travel to the United States to stay with her kids for about 6 months. She otherwise is ambulant for her age of 60 years. She is able to routine activities. She doesn't have any discomfort along. On the current visit, her examination is pretty much within normal limits. Her blood pressure, pulse, they are all right. There is no obvious murmur heard, and her lung sounds okay. She doesn't have any clinical signs or symptoms of heart failure or angina. She brings in a master health checkup that she got done because somebody suggested she should get a whole body checkup before she plans to go to the US. And in that master health checkup, there were routine laboratory findings, ECG, and echocardiogram. They all were pretty much within normal limits. There wasn't anything to write home about. She takes routine cardiac medications and medications for her diabetes. I'll list out those for you. She takes aspirin and clopidogrel as a dual antiplatelet combination. She's on 40 milligrams of atorvastatin, 40 milligrams of telmisartan, 5 milligrams of amlodipine. And for her diabetes, she takes tenligliptin 40 milligrams once a day, metformin 1000 milligrams twice a day, and she's on insulin mixed-start, which she takes 26 units in the morning and 18 units in the evening. She also takes pantoprazole domperidone combination and a multivitamin. So this is her regular medication, and she had been on it for quite some time, and she's doing all right. So the question that comes with us, and this is the question I posted in the invite as well, what would be a cardiologist's advice given her clinical scenario? Is she okay to travel or she's not okay to travel? Should we ask her to get some kind of online health insurance? Are there any other screening investigations or any treatment modification that we should offer to her? And should we advise her to carry a drug portfolio when she goes to the United States, other than the routine medication what she's taking? And while her plan is to stay there for 6 months, for how long she should take those medications, or for how much reserve she needs to have for all those medications? So I think all these questions are very routine in nature whenever these patients come to us. And what other advice we can give her to travel to the United States and stay over there. So Praneeth, I'm sure this is not the first time you are hearing this clinical scenario. If you could just walk us through what you do typically for your patients, and then we will ask our other attendees to weigh. Praneeth, you can take over.
Yeah, good evening everyone. I get reminded of our conversation while we were working up for Tower, where you said the unique association or uniqueness of Hyderabad is almost every family hold has a connection with the United States. So most of the patients who come are the retired parents and their kids are abroad. So it is a routine practice for them to go for 6 months, spend some time with their kids for 6 months. That is the period where their visa is valid, and come back, get them just re-evaluated, and again go back. That is how most of the retired parents are doing right now. So yes, this is a common scenario where they do have some these risk factors, hypertension, diabetes, and some are having coronary artery disease kind of stable, and they do. So how I would do is I would try to look at their cardiac status, about their symptom status, and what is their whether they are having any heart failure, and look into LV function. So first I would try to look into their rough functional class estimation as to their day-to-day activities, whether they're able to walk, do their household activities, trying to get an estimate of their functional capacity. And depending on their cardiac status, would look into an ECG and echo, look at their LV function, and if those patients who are already having LV dysfunction, trying to compare with their old records of how they are doing. And other than that, the basic labs of hemoglobin, creatinine, and the other stuff. In addition to what they are using, now that we have discussed about vaccination schedule for most of them, at least I am aggressively advocating vaccination, and as a part of travel as well, I would be advising them vaccination before they travel, because of the contact or the change in climate, or particularly going to a cold climate like US. I would definitely advise the flu vaccine before they go. Regarding the drugs that they take, I would suggest them to carry their medication, what they are using, which they were comfortable and using for quite some time. Try to purchase it for at least 6 months, and probably a month or so in case of any emergency where you end up landing there, and so that you don't get into trouble. So I ask them to carry all those medications labeled up with their expiries checked in, so that they don't end up having trouble missing their drugs while they're staying in USA. Sometimes the question comes as to, is there any other medication that we need to take, the over-the-counter pills? Again, you might add details better, but I believe the availability of the drugs are not so easy. There are only few drugs which you can get over the counter, unlike India. So some of the common remedies which they would like is something like fever or pain, where we suggest them to take some tablets of paracetamol. Sometimes a common cold, where you ask them to take some cetirizine. And these are the two things which I would ask them to take it. And some of them do ask for some antibiotics, etc., which I say not to, but in case if they want, maybe a strip of amoxicillin clavulanate, just in case an emergency to tackle common infections if we have. So this is how I would suggest. Once they are functionally in class 1 or 2, not much of a heart failure and stable coronary artery disease and heart failure, then I would definitely clear them to travel. And these are the medications which I ask them to carry with them so that they don't stop their medicines or skip medicine and end up having trouble. That is how I approach this case.
So Praneeth, this particular patient, and I'm going to ask you one question and you can reply with reference to this patient. Do you do a pre-travel stress test in these guys? And I will tell you, for functional assessment of this patient, she's at home, she does her work, she's doing fine, she occasionally goes out to shop and she's okay. She doesn't do any dedicated exercise at speed. And whenever she has to climb stairs, she prefers to take an elevator, but she can climb a floor without any problem. So this is the typical 60-year-old lady at home who doesn't report any functional limitation. She's just not exercising. So what is your take on doing stress test in these patients, particularly the case that I...
In this case, I would prefer not to do any stress test because I don't think she's having any active evidence of ischemia right now. She is relatively stable, and I would advise her to continue the same level of activity that she is doing, and ask her to avoid strenuous activity like carrying those heavy baggages or doing any strenuous activity. So I would prefer not to do any stress.
Perfect. Thank you so much, Praneeth. I am going to open the discussion for other people who join us. If Vrinda is with us, Vrinda, can you unmute and confirm that you can hear me?
Yes, I can hear you.
So Vrinda, this is a diabetic patient on 2 oral hypoglycemic agents and the insulin, which I get scared about whenever I prescribe. This patient wants to go to US for 6 months. What is your take on it? How are you going to manage?
As Praneeth mentioned, very frequently we do get to see such patients in our clinic, and I think it's very, very important if we can impart this message along that while they're traveling to a different time zone, temperatures will be different also. The insulin absorption could vary, so it's very, very important that these patients with diabetes, if they're planning to travel abroad for a long period of time, that they get in touch with their doctor about the possible medication and dose changes that may happen when they are staying in the US. So it's important. So I'll start my discussion with the patient regarding why are they traveling to the US, like if they have any planned activities, which is sometimes if they plan to go to a hill station or to planned like any activities which may increase their daily activity, then I have to tell them that when they travel to a different time zone with temperature changes, insulin absorption differs. So they may need to monitor their blood sugars more frequently. They should carry a glucometer with themselves and take adequate number of strips. Then when we are talking about this particular patient, metformin, it's also prescribed in the US, but enagliptin is actually not available in the US. So I'll come to the insulin part later, but I would definitely ask these patients to carry double the amount of medications than required for that particular time period. So like if they're planning a travel for 6 months, I would say, try and take double the amount. So like if, check the expiration date when you're buying these medications from the pharmacy, and then take the supplies for a good 1 year. When you're buying insulin, so now insulin is the tricky part because temperature, while carrying the medication also, like so much of insulin also, it's important to maintain the temperature during the travel. So, I'll particularly ask them to pay attention to the expiration date on the insulins. So when traveling, they can actually buy like a portable cooler, something with, they can store the unused and the unopened bottles or cartridges of insulin in the cooler, with a gel pack or an ice pack. And then any opened vials or cartridges can be carried at the temperature or the room temperature essentially. So that doesn't need to be put into the gel pack or the cooler bag. It's important, like I mentioned, to carry excess and supplies during travel. Put them in the the carry-on luggage essentially, so that you can maintain the temperature. If you put it in the check-in luggage, in the checked-in luggage, I usually tell people there are more chances of the insulin going bad because of the temperature changes. So the good thing about this patient's mixed-start insulin is that this is also available in the US as over-the-counter. So one important thing is that patients who are diabetic, who are carrying all these supplies like glucometer, test strips, lancets, syringes, pens, insulin vials, cartridges, they should absolutely carry a doctor's prescription along with it, and then carry the medications in their original labels. So like, don't throw away the labels. So if usually you have the doctor's prescription, security is not a big issue. People who may be using like wearable technology, something like a continuous glucose monitor or insulin pumps, that's a piece of advice for them. They cannot like go through the routine x-rays. So they would want to tell the security personnel up front that they be patted down and not go through the scanner. So those are important things to keep in mind. But in general, any people, with diabetes on oral antihypoglycemic agents or insulins, are allowed to carry all these supplies, insulins, disposables, glucometers, and they can carry the extras also with a doctor's prescription attached to it. And they should basically focus on maintaining the temperature during their flight, for which it's important to carry it in a cooler bag for the insulin, and then monitor your blood sugars much more frequently. So usually I'll tell the patient, we'll give a plan, put it out in writing, how the insulin dose may be modified if the blood sugars are running so and so. And then they should carry some sort of like medical identification card with them. If they're traveling alone, then I tell them to carry information for their next of kin, carry the doctor's business card or the visiting card, just in case of emergencies. So I think those are some nitty-gritty points that, I'll talk to them about before they are traveling to the US. One thing I was mentioning that teneligliptin is not available in the US. So usually if they are carrying excess or more than what they may need for over a period of 6 months, the supplies, they should be good. But just in case, they lose their prescription medications or, they run out of it, then I think, the fallback plan is the insulin, the dose can be adjusted to manage the blood sugar. Thanks.
So Vrinda, I'll just ask a few questions if you can be with me for a few more minutes, and then we can carry on with other attendees. Number one, you mentioned about carry-on versus check-in. Carrying 1 year worth of insulin in a carry-on bag, liquid, is that a problem?
Not usually. Okay. So if the doctor prescription specifically can mention why this patient needs so much of supplies, security is pretty good about it, letting through the patient.
Number two, is there any A1C cutoff beyond which you would say don't go, your sugar is uncontrolled?
Well, so if the travel has to happen, like, they have planned a travel already, I would certainly, and hope that they had better blood sugar control before travel. But if they absolutely have to go, there's no A1C cutoff. But I would basically tell them to monitor their blood sugars much more frequently. I would encourage them to check their blood sugars even on board, during the flight. And then if they are on insulin, I can give them some sort of a sliding scale insulin chart so that they can, dose the insulin based on it and try to get the blood sugars.
And you mentioned Mixtard there is over the counter. I did not know this. Can you tell which all insulin you know is over the counter?
So usually the older insulins, as we call them. So in NPH insulin, the intermediate acting insulin NPH, regular insulin, which is the Act Rapid that we use here, and the Mixtard insulin, the mixed insulin. So
Lantus is not over.
Lantus is not over the counter. It comes under the brand name of Relion. So we have the Relion N, Relion R, and we have the Relion 70/30 mix.
Okay, perfect. Thank you, Vrinda, for that. We are going to go forward with the discussion. Let me invite my other attendees. Dr. Chandramukhi, if you could hear me, could you please unmute yourself? We are discussing about this patient who is 60-year-old female, had a previous stent, diabetic, hypertensive on insulin, who is otherwise stable right now. ECG, echo, labs are all fine. She is minimally active at home. Whatever she needs to do, she is able to do. She wants to go to US for 6 months, and we are trying to figure out whether we should clear her, whether we should do some stress test, whether we should change her medication. What kind of advice are we going to give for her to travel to US, or we tell her don't travel? What is your recommendation? How would you handle?
Thank you, Anu. Good evening, all. In addition to all the investigations which are included in master history, I would definitely like to do the stress evaluation, functional evaluation, which may be in the form of treadmill test or DSC or stress thallium. So I would like to assess her functional capacity because during the travel in the airports, there will be a lot of stress and some people have to walk for long distances and carrying the, changing the flights, there will be a lot of stress. So I would like to do the stress evaluation in this patient, and as everybody has mentioned, we need to tell them to take all the medicines, adequate amounts, and also the prescription of the medicines is very important because they might be asked to produce the document of the prescription of the medicine. Thank you.
Perfect. Thank you so much, ma'am. Let me go ahead and see if we have somebody else. We have pretty thin attendance today. Dr. Vijay. Dr. Vijay, I am not able to identify you. Could you please unmute yourself, introduce yourself, and share your thoughts about today's discussion? Dr. Vijay, are you able to hear me? Okay, there may be some problem at the line. We have somebody with the name ST. I don't know who are you, sir. Can you please unmute yourself, introduce, and share your thoughts? Attendee with the name ST displayed. I can't recognize you. Okay, I'm not able to identify. Maybe my voice is not very clear to you as well. We have Salma here. Salma is our cardiology nurse who manages a lot of heart failure patients. Salma, if you are able to hear me, can you please unmute yourself? Salma, if you are able to hear me, could you please unmute yourself? Okay, looks like today there is a lot of technical front. Let's see. We have Dr. Zakaria here. Dr. Zakaria is our DNB resident at CARE. Dr. Zakaria, if you could unmute yourself, I have a few questions. If you could answer. Yeah. Dr. Zakaria, so you heard the discussion.
Yes.
When a patient like this comes to you, what are particular questions that you are trying to answer? If you could just share your thoughts, maybe we'll be able to answer some of those or address some of those questions in the discussion.
Yes.
What are the things
Yes,
you
sir.
are?
Yeah, I would like to ask her any recent complaint specific to cardiovascular system, like she had any episode of syncope or chest pain or chest discomfort or shortness of breath. Along with that, I have one more question regarding. I have one more question to the moderator. Sir, I would like to ask, I said this patient is at risk of developing, since long distance air travel, such patients are at risk of developing DVT. So, what should I ask them to take precautions in such case?
Perfect, Dr. Zakaria. Thank you so much. In my notes, there was one of the mention of DVT. You did bring that up, so that gives me a reason to discuss about it. Answer to your question about her symptoms, so she does not report any syncope or any chest discomfort or shortness of breath. Your question for DVT is registered. Is there anything else that you are thinking in your mind that you would ask others about this particular scenario?
Nothing as such, sir.
Okay. All right, let's see. I can see Dr. Johan logged in. Dr. Johan, if you are able to hear me, could you please unmute yourself? Dr. Johan, are you able to hear me? Okay, so technical problem is the theme for today. I typically reserve Dr. Somaraju's comment towards the end of it, but looks like I'm running short of people whom I can invite. Somaraju sir, I heard you had a template to prescribe to the patients, or suggest to the patient who were traveling to US. We are discussing a very routine clinical scenario. What typically you recommend to your patients, and I would like to hear whether you do stress testing in these patients before you advise them to travel to US. Dr. Somaraju, if you could share.
Good evening to all of you, and I think Dr. Vrinda covered almost everything, and it's a very near completion. Except a few things I just want to add, and we had a system and a protocol. Whoever travels to US, we have some advice printed, and also the travel medications, etc. And I also want to know, though it may look slightly odd, this patient needs to have her B12 estimated. With the stent inside and so much of higher risk she faces, B12 deficiency does produce an acute coronary event and stent thrombosis. And apart from saying that, I want to know on what class she is traveling in an airline and which airline she is traveling, and then how she has to conduct herself in the airline. Dr. Vrinda already pointed out, except telling that she has to move about, not go on sitting, not fold her legs and all that. Somebody already raised the issue of venous thromboembolism, and that has to be taken care of either by the activity you suggest or some drug you give. Then what is important in this travel is slight hyperglycemia is acceptable, but not hypoglycemia, and take care of it. And also the reason why somebody already pointed out the reason why she's traveling, and also always ask them to carry medicines at least more than 1 to 2 months extra than what they are trying to stay. Particularly routinely, they stay longer. Even with in these times of COVID, it's even more important that they take medicines more than needed for the 6 months. And if somebody has any specific issues, it can be answered. But it's a very important event and a very important case example choose, because it's taken for granted, and most of the patients are not well advised. I also agree with the people who said this patient who is not physically active and had already a coronary stent done, she needs some form of functional testing and to rule out significant coronary artery disease, because she is not physically active and absence of symptoms is unreliable in such a patient, particularly with diabetes. Thank you.
Sir, I have two questions particularly for you. One is, do you advise DVT prophylaxis in these patients? I'm quite fascinated with your question of which class travel and which airline. I typically don't question them the class of travel, but I do question them about which airline, because if they are taking a direct flight from India to US, then I am inclined towards prescribing them DVT prophylaxis, pharmacological, although I don't know if it is scientifically backed or not, versus if they take a break in between 7-8 hours, then I simply tell them to just be active rather than taking a prophylaxis. That is one. And second question is, other than the routine medication, do you have a list of standard medication that you tell patients to take, like NSAID or antibiotic or anything of that?
Yeah, we do have a list of medications outpatient. I won't enumerate all of them. There are incidental medications that people may need over a period of time when they stay. That includes, apart from some of the list Dr. Praneeth mentioned, even a course of antibiotics and other things as they and when needed. And also we ask them while they travel not to fold their legs and sit, and also move about in the airline on and off, and not sit for long hours, not to overeat, and etc. And what else you asked? I forgot.
So DVT prophylaxis.
DVT prophylaxis, if it is a long airline and somebody has risk factors, obesity and any other things, and as a routine, we give them low molecular weight heparin in the, before they start their flight here in Hyderabad. And then we do give that. And though the guidelines are divided on these issues, but indeed there is increasing evidence, as British Airlines came out with a document actually suggesting that there is increasing incidence of venous thromboembolism, and they are trying to be careful. And I think we try to have to be more careful than what routine guidelines suggest. I don't give the guidelines. We do give them venous thromboembolism prophylaxis more aggressive.
Yeah, this question of venous thromboembolism prophylaxis it did come up, I believe, a year or two ago, when there was one incidence of a patient getting hit. The incident was, I don't know gender, he or she was trying to take one of the carry-on bags from the overhead counters, and while doing so, the bag slipped from his head, got hit his head, and developed a subdural hematoma. And this happened while they were on a transatlantic flight. And at that time, the discussion of whether these patients being on anticoagulation would make things worse or not. So that discussion did come at that time. It's a fascinating thing to talk about. At some point, you are trying to prevent the DVT, but at the other hand, you know if you do bleed while you are up in the air, it can be really bad at the time. So that is equally important. Is there anybody in the audience who would like to share their thoughts or add more to the current discussion? I have pretty much pointed everybody's name, so if there is anyone who has anything to add, please feel free. One of the questions that is asked is, how do we monitor PT-INR for patients who are taking VKA or vitamin K antagonist while they are staying in US? And Praneeth, truly speaking, I do not have any idea. I do not know how they are going to manage their PT-INR. I don't know. Vrinda, do you know how they can get tested for PT-INR? I don't know if there is any over-the-counter reagent or any rapid. Vrinda, do you know anything?
There are freestanding labs actually which can wherein basically just like India, you can walk in with a request for blood test. So, in fact, one of the questions that I was actually going to pop up to the audience was what are the thoughts about, advising patients or getting a all-inclusive medical insurance, for them to be able to get these things tested and covered. But for the first part of the question that you asked, actually, there are freestanding labs. So I think it is worth a discussion if these patients are elderly, they have people next of kin living there, to locate such facilities and clinics which can be of help prior to travel. So that is like some kind of homework that they can do.
And do you know, Brinda, if county hospitals will cater to travelers or visitors?
No.
They will.
No.
One of the questions that is popped up. So PT-INR is just like a glucometer test in US, but that machine, I have seen it in typical hospital emergencies. I don't know if anybody can walk in and somebody can do it. I'm not sure about it. I don't think other than freestanding lab. One of the questions is, do you give them a separate travel certificate or ask them to take the OP book itself? I do give them a separate travel certificate, and I don't really certify. I just summarize everything in a single piece of paper on my letterhead. And the reason why is because many of the times our OP book is handwritten, and the information may be quite haphazardly placed. So you want to make it easier for both the immigration officer as well as people in the US who may question why you have so many drugs with you. So I think it is easier to summarize everything and just put it in a piece of paper with your phone number and your the way to contact, something that works, like an email ID or a phone number or something, because you may be able to save somebody's life if these guys, they call you back. And believe me, if an immigration officer is questioning the drugs that the patient is taking, they will not hesitate to call you. They may actually call you from there immediately to ask what's going on with this patient. So put your phone number, put your email ID. I think that is quite important to do. One of the questions is asked is medical insurance and how much medical insurance. So this is also, I will answer. And in the meantime, if anybody has got any comments, please raise your hand or you can unmute yourself to ask, share your thoughts. So, the travel insurance, what we have to understand is the patients who buy medical insurance, they're not buying medical insurance. It is not medical insurance. It's a travel insurance. It's an incidental insurance. It has a misnomer. It is read as a medical insurance, but it is not. It's an incidental insurance, which means it will cover what you did not have, the problem that you did not have at the time when you boarded the airplane, which means that if you had diabetes and if you have a diabetes related issue, no travel insurance is going to cover it no matter what you do, no matter how much money you pay, no matter what you do. Same thing goes, let's say if you are taking warfarin, and if you go to United States, they're not going to pay for your PT-INR because that is something you already had at the time when you walked in. Your osteoarthritis, you go there, get a knee replacement, they are not going to cover it. It's incidental. It is something that happens which you are not expecting. You go there, get an infection. That is what travel insurance will cover. You go there, get an accident. That is what travel insurance will cover. But they are not going to cover you for the so-called pre-existing illness. And nitty-gritties about medical insurance, whenever your patient is taking one, they need to include the days where they are going to be in the aircraft. So they should not simply just take the days when they will be in the US, but they should take the days when they will be out of India. Because if you don't cover that one day when you will be in the plane, and if, let's say, you catch something in the plane, they will not cover when you land to the United States. So it is very important for you to cover a day before and a day after you land, just so that they cover you for any incidental that may happen within the plane as well. And how much? I typically take anywhere between 1 to 5 million US dollars. And I think bare minimum you should take $1 million coverage with you, because if you do need healthcare services there, then you will need a lot of it. So typically $100,000, $200,000, they don't do it. You should definitely take at least $500,000 to $1 million coverage for you for that. Copay, you can decide how much to take. I shared my protocol. If I were treating this patient, I would do a functional stress test on this patient. I typically do a TMT or something to assess if their functional capacity is okay. Once a while, you find a patient who can walk around, who are jogging, who are doing everything. In those cases, I don't do it. Because remember one thing, in the United States, a typical person will end up doing far more physical activity than what they do it in India. That is just given, no matter where you are going, whether you are going in a warmer climate or a cold climate, you typically end up doing far more physical activity in US than what you're doing it in India. So doing a stress test is not a bad idea. I typically do DVT prophylaxis in those patients who are taking a direct flight, where you are talking about 15-16 hours in the airplane. These days, Hyderabad started direct flight to Chicago as well, so that question will come up. There are a lot of direct flights from New Delhi, where people from Hyderabad, they take a hop over in New Delhi, and from there they take a direct flight to US. Again, we are talking about a 15-16 hour flight. I typically give them DVT prophylaxis, and I tell them you just take a 40 milligrams of Clexane, and that should take care of it. People who are low risk for DVT, but they are at a higher age group, and if they are taking a direct flight, I tell them to take a full dose aspirin as a single dose. I don't know how much it helps, but I do tell them to take 4 tablets of aspirin, mix it in the water, and take it an hour before you fly. Whether that has got any role or not, I highly doubt, but that is what my practice is. In the airplane, most of the things are covered. Hydration is very important. Even if you have a patient who has got a little bit of background heart failure, it is important for them to keep themselves hydrated in the airplane, because airplane air is very dry, so they tend to become dehydrated. And in the same note, they should avoid tea, coffee, alcohol, because they do produce dehydration. Remember, dehydration is a precursor of DVT, so you should try to keep them hydrated as much as possible. And the other thing is, the world of over-the-counter in United States is quite different than that of India, and we will be surprised how many medications are available over the counter in the US. So whenever you have a patient who is traveling for the first time, it's a good idea for them to go and quickly just browse over-the-counter medication shelf around their place, just to see what all medications are available, because there is a good chance, if they know what all medications are available, they can stop panicking in case if they need those medications, like antacids, pantoprazole, paracetamol, which comes there as Tylenol, and NSAIDs, and all these. Those are easily available. And what Vrinda said, insulin is available, which I did not know, that insulin is also available on the counter. So these things will help them. 2 things for us as a care provider. Paracetamol in US is called acetaminophen. So there is nothing called paracetamol in US. If they start looking for one, they will not find one. So we need to be aware that the term there is acetaminophen. And similarly, salbutamol, what we call in India as asthalin, salbutamol is available in US as albuterol. So it is the medical term or the generic term for salbutamol there is albuterol. So if they keep looking for salbutamol, they will not find one. But albuterol is over the counter available. So those things are for us to tell the patients in case if they want to add. So that is overall. I agree with that. Yes, sir. Yes,
can I say something? Thank you very much, and it was a lot of education session. It was very exhaustive and very well covered area, and usually this area is neglected. And particularly thank to Dr. Vrinda for giving us some insights into diabetic issues related to this travel. But I just wanted to say 2 things. One is US insurance. Less we talk about it, the better now. They say there's a joke when you fall down from a building, only falling down will be covered, not getting injured. And secondly, I also want to say, if this patient you are talking about heard all these things we talked about, she won't go to US. She will stay back.
I hear you, sir. I hear you. I think so. We certainly, when we discuss with patient, we need to discuss in a way that we don't discourage them from their plan. Absolutely right. That is something we should keep in mind. Anyone else has got any thoughts? The travel insurance part, what Dr. Somaraj said, I covered it. It does not. It is not your healthcare insurance. Let's be very clear about it. So people who go there thinking that they are taking insurance and their incidentals will be covered. Remember, if you are a diabetic and if you get an MI there, they will not cover it because they will consider diabetes as free. Just to give you an idea of how these insurance companies work. So the only two things, in my opinion, which they will cover is infection and accident. So those are the two things that they will cover. Anything other than that, just don't count. Their business model doesn't allow. So that I would suggest. If their family members are citizens in US, you can go there and they can add you in their existing healthcare plan, provided you go there in an open enrollment period. Open enrollment period is a weird thing to understand. In US, you cannot just buy health insurance any day. There are enrollment periods which are there few months or few weeks of a year. There only you can buy healthcare insurance. You can't just buy any random day. So if you happen to go during that time when there is an open enrollment period and you are directly related to a citizen there who has healthcare insurance, then they can add you to their insurance for that year, not for 6 months, for that year, and they will pay premium for that. Then you will get the healthcare insurance that. So that is possible. And that is something you can plan with the patient in case if your patient you think will require healthcare services over there, then that is something you can plan in that regard. And also remember one more thing, US emergency works for visitors as well. So even if you do not have insurance, if your patient is in US and gets in serious trouble related to heart or whatnot, even if they don't have insurance, they can still go to the emergency and get services. The services will be available to them. It won't be free of cost. They will bill you. And even if you cannot pay over there, that is okay. They will do whatever they can, but you will get the healthcare service. So it is not that because of your payment scenario, you will not get the healthcare. You will get that. So in case if you are dealing with a dire situation which is life-threatening, they can go to an emergency. There, they should not think of whether insurance will cover or not. They will get the treatment. So that was my thought on the travel part. Anybody has got any thought? The duration of treatment, I tell people to take double of this. So if they are going for 6 months, I tell them to take 1 year. If they are going for 3 months, I tell them. And I typically tell them to divide it into half and keep it in different bags so that your number of medication does not alert or does not trigger when it goes through an X-ray. You don't unnecessarily want immigration to get triggered because of a huge chunk of medication that you're taking. It is particularly important for those drugs which are not US FDA approved because for them, the DEA over there is very strict. So let's say if you are importing tenligliptin or if you are importing domperidone, which are not US FDA approved, they will be far more stringent on that. So it's not that you can't use it for your own. You just have to make sure that you have a proper document. Because those drugs DEA may trouble when you are in. Okay. Any other question? Praneeth, you want to add anything of the discussion that we were having, particularly with relation to how to travel, what else to do, any other different patient scenario that you had, and how did you handle any, if you want to share any experience?
Nothing in particular. These are the only things about the things patients on anticoagulants how to monitor, because we are very strict, and particularly those patients who are taking those mineralocorticoid receptor antagonists, where we tend to check their electrolytes and all. How do we monitor their electrolytes, which we are used to ask them to monitor frequently, which we are not doing for that 6 months, and even sugar monitoring. So I think that Vrinda told strips we can help, and some over-the-counter labs which can help us know it. And maybe with the advance in technology now, even though patient stays away with these WhatsApp or other communication, probably we can still be in touch with the patients and monitor them. That's what I could think of.
Yeah, so if patients require frequent labs in terms of their potassium management and whatnot, then that is one place where I modify their medication regimen in a way that frequent lab tests are not required. So it's something like, if I am fine-tuning medications here and keeping potassium aside, I don't have that liberty in the US. So there I would like to get their potassium drop and then only do something. Remember that the labs over there, they will do, freestanding labs will do tests if you write prescription, but then you will have to pay for it. And then the self-pay model for even simple tests are quite costly. But you can get it done, provided you have a formal way of handing out prescriptions to them. That they will accept. They will accept foreign prescription for simple labs like potassium or all things. Vrinda, anything you want to add? Your hand is up.
Oh, I was actually just going to mention the same thing, that I think with changing times secondary to COVID, in my most recent experience, 2 of my prescriptions through telemedicine actually have been honored in the US. So, but of course, the patient had to, cover out-of-pocket expenses for the prescriptions as well as the labs. So, but they do take in foreign prescriptions.
So in US there is this concept of generic medication. So if your patients do need to buy medication there, they can opt for generic versions of it. And if that pharmacy is accepting foreign prescription, then the generic medication won't cost that much. There is a $4 plan and there is a $10 plan where a patient can get a month supply for $4 or 3 months supply for $10, provided those medications are within the generic list. And those generic lists are online available, so anybody can simply just Google it. So let's say there is a Walgreens pharmacy. If a patient says, I have a Walgreens pharmacy next to me, you can just Google Walgreens pharmacy generic list, and you can modify the patient's treatment regimen as per that generic list. And if that Walgreens will honor your digital prescription, then they will be able to provide the patient with a $4 prescription, and that will be quite economical. To share, one of my patient, he is stuck in US for the past 1.5 years in this COVID. So he actually traveled somewhere around October, November or so, and he has not been back to India since then. And he is a typical cardiac patient, elderly, 70 plus, with previous angioplasty and all those things. He went there for a 6-month plan, took 6 months medication. Then he got stuck with COVID. And just to share that, for 2 times we were able to shift 6 months medication to him. So the way it was handled was, I wrote a prescription on my pad with all the medication, and one of their family member locally, they were able to procure those 6 months medication, give it to a courier agency, and courier agency was able to courier that medication along with my prescription. And that medication was delivered to him twice. So I know that in the old times, the US imports were very particular about importing these medications. But at least in the last 1 year, I have been successful twice in doing so. So maybe, as the times are changing, even US immigration is not being that stringent about importing regular medication, provided they have a standard. So these things are, of course, learning for us, but patients going to US and being in US is not unusual for us, particularly people staying in metro cities like Hyderabad. And we as a doctors, we need to be well aware of all the tips and tricks and all the idiocies that happen around the travel. So I hope we covered some basic points, and we are 8:31. If there is any other questions that comes to your mind related to this, not just for this particular patient, as a general for patients traveling to US, please feel free to share. If there are no more questions in the next few seconds, we can close the session. Okay, doesn't look like there are any other questions. If you do come across any question offline, please share with us. We'll be happy to answer. Me and Brinda are placed in a position where we were working there, so we do kind of have a little bit of idea of how US works. Certainly we are better placed in that scenario. Rest of us are better placed in the scenario where you understand the Indian setup far better than we do. So if there is anything that you would like to know about how US works, we'll be more than happy to share our idea. If there are no more questions, I'll close the session. Praneeth, your closing comments for sessions like these, which are not directly pathology related, and how we go forward.
Yeah, no, I would say this is definitely something which is important. Someone like me who hasn't been to US and doesn't know what are the way things are practiced or how are the practical considerations when someone goes to US. It's equally insightful for me when if I go to US, what are the things that I need to be prepared for. So yes, with this huddle discussion that we had, with more confidence we can tell the patients the additions, particularly the management of diabetes, about the insulin, which patients are a lot worried about and carrying the drug. And equally, not to panic that yes, there are lab facilities available in case you need. Yes, you have to pay for it, but yes, there are those facilities available, and now with technology, we can be in touch and probably take the help of friends or colleagues available there in USA and try to manage the patients better. Hopefully, technology helps us do this better. So yeah, definitely a good topic, and these are some things which are not there in textbooks. So unless we discuss these things and share our information, these things won't come out. So I think this is a very good topic that we had today.
Praneeth, thank you so much, and thank you, Brinda, and thank you, Somaraju sir, for your insights on this. I again remind all of the attendees that if you find these sessions valuable, would you please share it with your colleagues so that we can have more participation and more discussion on any particular topic that we choose. Also, if you think there is any particular topic that we should be discussing in our huddle, please share it with me or Praneeth, and we will try to see how we can fit in our future session. It doesn't really have to be medical pathology related. It could be anything related to our daily practice, lifestyle or whatnot. Having said that, the sessions are recorded and they will be available online on podcast and YouTube, so you can subscribe. And I hope I see all of you next week. Till that time, if you have any feedback or any questions, please feel free to reach out. Thank you all for attending today. Have a good night and see you next. Thank you.